Good morning. I know there is other session going on the other side, and a few people are sitting there, so I think that session is being finished, and but we have to start in time. So we have a great session this morning. I welcome you all, and we'll be starting with the session today, which is a joint session with Society of Cardiovascular Angiography and Interventions. And we have the SCAI team as well as someone sitting here from SCAI as well. So it's going to be a great session. I'm sure that we will have a great case as well as a good talks from all the international speakers from SCAI and PSIC. So I would like to invite my co-moderator, he I think just went out, Professor Fizullah will be helping me during this session. And we have, again, excellent and experts from SCAI. Dr. Sunil Rao, who is the current president of SCAI, Society of Cardiovascular Angiography and Interventions. He will be joining us virtually. Dr. Duane Pinto will also be joining us virtually. He's again an excellent interventionalist, a very well-known expert from US and part of SCAI team as well. Dr. Ramesh Dagabati, he's again an excellent interventionalist and a very active member of SCAI, involved in several SCAI activities, including he's the chairperson of international committee of SCAI as well, which I am part of that committee. So he really helps us a lot during these international meetings, sessions, and the SCAI International Committee. We have another excellent person, Dr. Ahmed Magdi from Egypt.
I'm just asking why there's a time zone that's a half an hour off from the other.
No. I'm sure it's just to be different, Duane.
Yeah.
Sunil, can you hear us?
History goes back long ways.
Tell them to hold off 1 second. We have Dr. Ahmed Magdi from Egypt, and I'm really grateful to him. He's an excellent operator and also, again, very active member of SCAI team as well. And he's actually very early for him, and he woke up at 5 a.m. in the morning to be part of this session. I'm very grateful that he's there as well. So the members from PSIC who are here, I would like to invite Professor Abdul Samad to come over here and join us as chairpersons. Professor Shahriyar Sheikh, Dr. Noori, I'm not sure if these people are here, Professor Nadeem Rizvi, who is the current president of Pakistan Society of Interventional Cardiology, Professor Zubair Akram, who is the president-elect for Pakistan Society of Interventional Cardiology, Dr. Azhar Kiani, who is the past president of Pakistan Society of Interventional Cardiology, Dr. Muhammad Sarwar, and I can't thank enough one of my very dear friends and colleagues who has come all the way from US. I think all of you are familiar with him, Professor Tanveer Rab. He is representing SCAI over here, so I would request him to come over here and join us on the podium. Professor Fizullah, please come us. He will be helping me as a moderator. I would request Dr. Afsar Raza. He's again part of our PSIC team for a long time, and he has come all the way from UK and has helped us a lot during this meeting. So Dr. Afsar Raza, please come up and join us. So Dr. Sunil Rao, can you hear me?
Hear you.
Okay. So we also have Dr. Ehtisham Mahmood, who is the past president of SCAI, and he will be later on doing the case and going over this. He has been again a part of our Pakistan Live for a long time, and we really are very grateful to him. He has always supported us in all the efforts of PSIC as well as Pakistan Live. I would request Dr. Sunil Rao. First of all, I would like to thank you for being here. Dr. Sunil Rao, Ramesh, Ehtisham, and Dr. Ahmed Magdi, and Duane Pinto if he's here. And we are grateful to SCAI for really supporting us and helping us in our meetings, as well as our colleagues here in Pakistan in terms of education and other things. So I'm very grateful. I would like Sunil Rao to please say a few words before we move on to Dr. Mahmood for the case, and a few words from him as well. Dr. Sunil.
Yeah, thank you, Bashir, and thank you for inviting me. Congratulations on your meeting. SCAI is proud to support meetings like yours that really provide an incredible educational experience for all the attendees. SCAI is an international organization. We are made stronger by members like you. So thank you for allowing us to be part of this wonderful meeting.
Thank you. Thank you, Sunil, and we really appreciate it, and we hope that SCAI will continue to help us and support us in terms of education, training, and teaching and research in the future as well with the PSIC. So, Dr. Ehtisham, over to you for the case, and you can say a few words, and then we can start the case. Thank you.
Great. Thank you, Bashir. And thank you, everybody. I wish I was there in person. As I've told many of you in the past, I lived in Islamabad from the age of 12 to 17. So it's a city that's been crucial in my formative years. And I really wish I could have joined you in person. I want to thank Bashir Hanif for the partnership between SCAI and the Pakistan Society of Interventional Cardiology. We will, of course, continue to support and hope that as the years go on, that we can build this collaborative partnership. Now, I was supposed to present a live case this morning, and let me tell you what happened there. It's never happened to me before, but there's a first in everything. And UC San Diego, which is where I work, their compliance office essentially, and I've been doing live cases for SCAI, for TCT, for my own meeting, but they would not let me transmit because I had not gone through a long compliance process for live cases. So this is something new, and I will work on it. It's going to take about 3 to 4 months, after which I can restart doing live cases. So with that in mind, what we decided to do is I did not want to just present a case in a box because often those go very smoothly and everything looks great. So this is a case that actually is a real live case that I did at my last meeting. It's a case that's a fairly complicated and complex case. There's intravascular imaging, there's hemodynamic support, there is a portion of it that's robotic, there's a DK crush for left main, and there's a complication that occurs during the procedure that you also get to see how it's managed. So I think this will be the closest to the experience of an actual live case. And I'm very appreciative again to Dr. Bashir Hanif to be able to work with me on editing it in a way that we can present it here today. What I will do is I will start the actual presentation and let everybody watch. There'll be portions I'll stop so that the panelists can comment. You will also hear some audio intermittently from the panelists when I did the case live. Tim Henry, Gira Weiss, Bill Penny, and Rajiv Johar were the panelists during the actual case. So the case is from not that long ago. So we'll get it started, and bear with me as I get a few of these technical aspects sorted out. But I think that we will have time at the end for Q&A as well, and I will stop it. And I think to the panelists, I'll say that if there some portion of it that you want to make a comment, or you think, let's stop and have a discussion, feel free to just interject and I'll do that. But here we'll get started.
Ehtisham, just I want to, I guess I named all the experts who are
We have the same team. Sorry, is that
sitting over
fine?
here, and I think in between we'll stop and get the comments from our panelists over here, and I have Professor Fizullah, who is helping me in moderation, so he might be interjecting or questioning in between. And we will also try to involve our panelists who are there virtually, including Dr. Magdi, Ramesh, and Sunil. So please go ahead.
I did not make that out.
Bashir, we weren't able to hear whoever was speaking last very clearly.
Can you hear me now? Dr. Mahmood, can you hear me now?
Sure, we can no longer hear you.
Okay, just
And so I've
wait.
not yet started the video. If you'd like me to do that, please let me know.
I think they are fixing, there's some issue. Let's see. Yeah, can you hear me now?
Yeah.
Much better. Yes,
Okay.
we can.
Okay, so sorry. So I was just saying that we have a great panel of experts over here, and Professor Hafizullah is with me, who will be moderating along with me. And any questions, we can request you to stop and we can discuss. So the virtually you have Dr. Magdi and Duane, Ramesh, and Dr. Sunil Rao.
That sounds perfect. I've got, let's see, 1, 2, 3, 4, 5, 6 planned stoppings during the presentation. So there'll be 6 times to have a conversation, but if people want to stop at any other time, let me know and I'll stop it.
Okay, sure. Go ahead, please.
Okay. Rodrigo Mandrachaga, our fellow. Lauren Sang is behind me. Tomas is our tech at the table. And if we just swing over to Brandon, Ashley, and now we have, where's Christy? We have Christy, our runner, in the back. And we also have Patty. So we've got same team, minus 1 person. We changed to Christy to get our equipment. What we'll do is Rodrigo will introduce this case. It's a pretty complex case. I want to talk about where we are with it right now. And then we'll do some aspects of it now, and then we'll go back to Dr. Patel. Rodrigo is going to give us a quick intro.
Great. Welcome back, everybody. So this is a case of complete revascularization with hemodynamic support and robotic assistance. Next slide, please. So this lady is 58 years old. She presented with stable angina and a cardiomyopathy with an EF of 40%. EKG showed no ischemic findings. Like I said, her EF was 40% with normal RV function. Her EF had actually improved from 17 to 40% with medical therapy in the past month before getting her catheterization. Current medications include amlodipine, aspirin, atorvastatin, carvedilol, furosemide, and Entresto. Her baseline creatinine is 0.7. Next slide, please. So she presented to the cath lab for a catheterization and was found to have this distal left main bifurcation disease with a Medina 111. There's also kind of a 50% mid-circ into the OM. Next slide, please. Another picture, we can also see these distal left main bifurcation disease and also diffusely narrowed mid to distal LAD. Next slide, please. Her RCA also had this mid-vessel severe lesion.
All right, that's my first stop. Thoughts about what would be the approach in this patient, 58 years old, EF 40%, distal left main, prox to mid right coronary. Thoughts?
Shami, does she have, what are her symptoms? Is it just angina? Does she have, she obviously is on goal-directed medical therapy for heart failure. What is the status of her clinical heart failure? And during this diagnostic cath, did they happen to get an LV EDP?
Yeah, great question, Sunil. So her heart failure symptoms were her predominant symptoms previously. They've actually improved, as has her ejection fraction. It was, mid-teens. It's now 40%. When this diagnostic cath was done, it was more for persistent recurrent anginal symptoms. So the feeling was that she has now angina that's predominant over her heart failure symptoms. And I can't remember what her diagnostic cath EDP was, but when this particular procedure was done, it was in the low 20s.
So let's see, we can get some comments from other panelists on Zoom. Ramesh, what would you do, or what will be your approach in this case?
Yeah, thank you, Bashir, and great case, Shami. This is I think, a very complex patient in terms of multivessel disease. You have to talk about complete revascularization with or without hemodynamic support, and single versus two stent strategies for the left main as well. So this is how I would start, as Sunil was saying, get an EDP or a PA catheter, PAPI index, calculate that, and get a FFR wire into the circumflex to see if that lesion is even significant. The reason being, the definition study included people with these type of lesions as a simple lesion, and I mean the ostial circumflex appears to be tight, but the length of the lesion is short, and so probably we can get away with a single stent strategy from left main to LAD. And obviously the RCA is also significant, whether you can stage it, do RCA first and bring the patient back for left main, or do all in one sitting is also something that we can talk about. I think these are the points that will come to my mind. Number one, is it one stent or two stent strategy for left main? Number two is a DK, it's a hemodynamic support. Number three is timing of the complete revascularization.
So let me just ask the question, because it probably was asked as well. Is there a reason that bypass surgery was not considered, or is she not a surgical candidate? Did she refuse?
Yeah, so Sunil, you beat me to the punch as always. So that I think any time in cases like this, that's one of the most important and first questions. So CT surgery was consulted. The patient was hesitant, but the surgeons also felt that the LAD was not a good target for a lima. And so that was the tipping point, even though the syntax score, by the way, is 31 for this patient.
So I don't know. I think the lima is perfectly fine, but would be perfectly fine on that LAD, but I'm not a surgeon. But I think complete revascularization at the same sitting. I'd be concerned that in that caudal view, the distal left main looked horribly tight. And I'm maybe wanting to look at it a little more carefully, or perhaps look at the circumflex with IVUS. And I think, going to end up doing a two-stent strategy. And that moderate disease too in the circumflex, I would end up fixing as well.
Perfect. So let me get to the next point. I think a lot of the key issues have been brought up.
Ehtisham,
We'll
can I quickly get a
Yes.
comment from here? Like Tanveer Rabb is sitting.
Of course.
Tanveer Rabb is sitting here, so I would like to ask him how would he approach this case?
Hi, Shami, Sunil, and
Hey,
Duane and Ramesh. How are you? So I beat you to the punch to Islamabad this year. So can you re-show the angiogram, left cornea angiogram for me? Because I missed out on that part.
So it's going to come up in just a little bit. I don't want to go back on this and mess up the whole video presentation.
Okay, all right, okay.
But basically what you see is a distal left main that is very tight, like Duane pointed out, and it does extend into the ostium of the LAD, and whether it extends into the circ or not is not as clear.
So obviously you want to evaluate the circ as best as you can, but lesions less than 10 millimeters in length really do classify as being a simple lesion, as Ramesh pointed out, and you try to go with a one-stent strategy. But of course, if the ostium circ requires further intervention like debulking of any kind, and you're going to perform some kind of maneuver there, that it might end up with a two-stent strategy. If the circ is tight, some folks will say start in the direction of the circ with a single stent and then balloon open the ostium of the LAD. But I generally favor just trying to go LAD back to the left main and see how it goes. But I think you would have to evaluate the circ little more before we decide what kind of strategy you do.
Okay.
I also would like to bring up one more point for the friends from Pakistan. Obviously, you have the capability of doing drug-eluting balloons, and I think also as well as in Dr. Magdi, Egypt as well, and India has them available. Unfortunately, we do not have in the United States, so that's another option, single stent strategy with the drug-eluting balloon to the circumflex ostium.
Great.
Can I ask you also simple question? If there is any way that we can make sure where the severe ischemia is in the territory of the LAD or the CX or right or everything, and there is anything to tell us about the viability? Did you have any MI before or not? The other thing is, I think this case when you are doing the left main intracoronary imaging will be very crucial in determining what will happen to the CX.
Great comments, Dr. Magdi. And you're absolutely right. Intravascular imaging is a crucial adjunct. And as far as viability, though that was not done, all the walls were moving on the echocardiogram, and the feeling was that a dedicated viability study was not necessary. All right, so.
Next slide, please.
Let's move on.
So in
to-
summary, she's 58, stable angina with a cardiomyopathy, EF 40%, a complex anatomy with a syntax score of 31. And the plan, after discussing with the surgeons and with the patient and having a heart team meeting, is to undergo PCI due to a poor Lima target on that diffusely narrowed mid-to-distal lady, and also patient preference. So she was loaded with ticagrelor and presented to the lab today.
All right.
Shami,
so,
your
as-
hospital is full of Protect 4 patients.
Can you believe it? So
You're
there's
jealous.
another Protect 4 patient. And let me start by showing you the femoral angiogram. So we did this femoral angiogram. It's a large femoral artery. We went ahead and placed an Impella CP. You can see the placement here. This is a single access approach. So through that single access, which at some point we'll show you what that looks like when we come back into the room. We've got a guide catheter engaged the right coronary artery. As you noted from Rodrigo's initial images, the mid-right's tight, the distal left main bifurcation is tight. Lima LAD was a poor target, which was the reason that we're doing this percutaneously. So we're going to start off by doing the right, then we'll go to Dr. Patel, and when you come back, we'll work on the left main. So hemodynamic support in place. We're using bivalirudin for anticoagulation.
But we cannot force, right? There's informed consent here.
100%. I had a. So what I wanted to quickly show here is for anybody who's not familiar with the robot, most of the panelists are, but maybe in Pakistan, I know people have not seen it. So that's me at the console. On the extreme left, that's the control to advance or retract balloon or stent. In the middle is the control for the guide wire, and on the right in the green is the guide catheter control. So after the hemodynamic support had been put in place, we actually did this right coronary artery completely robotically. And so we'll, as it's playing, feel free to, what I'll do is I'll mute the other panelists so that we can kind of talk about it as we watch what's going on here.
So Shami, what drove the decision for Impella here? It's EF is 40%. You know, it's not an EF of 15%. It's not last remaining vessel. You know, the EDP said it was in the mid-20s. It's sort of higher than you'd like. You know, I think in many places where they don't have this expensive technology available, you could, you know, could do this with a balloon pump and radial approach.
Yep. So I think those are some of the comments. And as we move to the left side, important comments and quite relevant comments to here's a meeting that's going on in Pakistan where I don't think Impella is going to be widely available. I know it's available, but not widely.
Yeah,
And so
Sham,
the question really,
Sham, can I,
You know, one of the
can I ask something here? Because obviously we don't have Impella in Pakistan. So I would like to ask Professor Nadeem Rizvi how comfortable he would feel doing such a case with the balloon pump alone, yeah, or even without balloon pump, because obviously not every lab in Pakistan even have a balloon pump. So let me get comments from him, and then we can see.
Yeah, and as you're getting comments from him, I want to just highlight one point.
Sure.
As you see, that balloon is after the post-dilation. So there are 2 stents put in the mid and prox right coronary, but the manipulation of the stent balloon is being done robotically. And so as you're thinking about that, watch that balloon come back, and you see my hand controlling how you can move devices in and out with a robot. Go ahead.
Yeah, thank you very much, Dr. Bashir Hanif. Yeah, I think in Pakistan, we usually use the balloon pump whenever there is an acute situation. In chronic patients like this with an EF of more than 40%, I don't think that we would like to use a balloon pump here. We would always have a backup, but that's the only backup we have here. So, but the logistic problems, because we are doing right, I think the more older the patient is, the more frail the patient is with a good EF, it'd like to go in and out quickly. And that's why, considering the stent strategies as well, I think usually in a distal left main like this with triple vessel complete revascularization, I'd like to use upfront two stent strategy without a balloon pump initially. But if within the procedure the patient's hemodynamics deteriorate, then yes, instead of with inotropic support, I'd be having the groin prepared and use the balloon pump.
Thank you.
So I have a slightly different philosophical position in that we can't prove the counterfactual that a case goes well in many instances with or without mechanical support, unless, for example, the person becomes pulseless. And if really the person is becoming pulseless because of some catastrophe on the left, a balloon pump's not really going to do anything. 20% more of zero is still zero. So
I mean, you could say that for almost any PCI, Duane. I mean, you could say that for a type A lesion, right?
That's right. And so
anything
we're
can happen.
actually,
so why not you can call it in every case?
Because we're actually gambling on the risk. So, the comment was made, let's get in and get out quickly. I think that that's a slippery slope when the complications start to happen. So we really want to do the left main properly, which involves imaging, which involves optimizing the pot and the second pot and all the steps of the DK crush that we're going to hear about. But if you just go in and the person starts to get sick and hypotensive and you start cutting corners in the procedure, then, we might have gotten through the procedure, but we haven't done the best job that we can in the procedure. But yeah, there's a gradation, and this is, a gradation. So there's the type A lesion, which we can all agree is not necessary in the hemodynamically stable patient. But where do you draw a line when you don't know anything of what's the right answer? And that's why I think this is the right patient, as Tim mentioned, for the PROTECT 4 study, is at least trying to figure that out. Is this type of patient turned down for surgery with an EF of 40% who has risky anatomy? What's the answer? Is it the question that was posed or not? And hopefully we'll get some answers in a few years.
I think it's very hard to show a difference if you're including patients.
Sorry,
with
Ehtisham, can I just interrupt the panelist? I just like to ask you that if that is the scenario, we do quite a lot of left mains and triple vessels. So if there's someone with an EF of 40% plus and an ETP of 21, and we are talking about in Pakistan something like $4,000, $5,000 for an impeller, at least. I mean, in that case,
more actually.
Yeah,
more.
In that case,
$25,000. Yeah, if they're $5,000 in Pakistan, I'm putting like 20 of them in my suitcase and bringing them back to the U.S.
Yeah. So my question is that in an academic argument, where do you stop? Then you should, from that argument, what the gentleman's saying, we should be putting in impellers in everyone who we are doing triple vessel revascularizations with a normal EF or near normal EF.
Yeah. So I think you heard the 2 points of view from Doctors Rao and Pinto, and I think they actually reflect exactly where our current understanding and the range of opinions are about what approach to take. The PROTECT 4 trial, which is currently ongoing, it's got about well over 100 patients enrolled, is randomizing patients like this one to and it's an interesting randomization. It's randomized to hemodynamic support with Impella CP versus either nothing or balloon pump with, if in the case of hemodynamic collapse during the case, you have to use ECMO. So it'll be a fascinating trial. It's going to take a few years to come up with a definitive answer, one way or the other. But I think what you're asking is the practical answer. What do you do here and now today? And certainly what do you do in Pakistan, where in the US, it's a $25,000 device. And even though there's going to be this newer 9 French device, which will likely be cheaper, it's not going to be widely available around the world. So we don't have an easy answer. I think my answer to you would be a case like the one I'm showing here. I would not attempt this without some support. So if balloon pump is the best support I have, then I would use it. Understanding that in the case of hemodynamic compromise, things could go awry. And so I just have to understand what my local support is. And one other approach to take, which I think a lot of us have taken over the years, is to stage these procedures. This is why I did the right coronary first, by the way. And it might be you do the right, and then you come back and tackle the other side at a different setting. So, so let's keep going. But I think the question of hemodynamic support or not, Sunil brought it up at the very beginning, and he also asked, well, what about this particular case? And so Sunil, one push for me was that her baseline EF was actually quite low, and she went up. So this is completely anecdotal. If I have somebody whose baseline EF is 55 and goes down to 45 with new or 40, I am less apt to use support. But when they sit at a much worse baseline ventricular function with medical therapy got a little better, I have a tendency to use more support. And certainly if I'm going to use debulking, or if I think I'm going to have a prolonged ischemic time. So let's keep moving because we've got a long ways to go through this case, and keep those questions in mind.
Shami, very quickly.
The left side.
Shami, your comments about the studies out of Washington Hospital Center and one from Europe where they optimized patients and they had good outcomes too before they did the PCI in people with complex anatomy like this. Your thoughts?
So let me, so Tanvir, let me start this again, and I will give you my thoughts on that in just a moment.
Yeah.
Because I don't want to get too far behind. We have a certain time.
We have to move because time is short. So just quickly
So
show it.
let me just run this because, so we finished the right and now we're moving to the left side.
No, well, come on, Tim, I gotta work once in a blue moon. Okay, so let's look at the angio films here, and I'll show you where we left you guys. This was at 3.5/24, and this is what the angio looked like after the 3.5 stent balloon to post dilate. I didn't like that, so went with the 3.75, non-compliant up and down, and that's our right. So looked a lot better. So then we flipped over. Here's the guide in, you can see the distal left main, and you can hopefully see it better. It extends into the LAD and the circumflex. So we wired both, and we have a 2.5/15 balloon in the circ, 2.5/15 in the LAD, and then we went ahead and IVUSed. So we're going to show you the IVUS of the circumflex and the IVUS of the LAD.
Hey, Rodrigo, why don't you play the first run? This is the first run from the circumflex back to the left main. You'll see some the disease of the left main approaching right there. The minimal luminal area of that is 4.5. Rodrigo, why don't you click on the bookmark B1? So here with the measurements here, this is the EEL dimensions, 4.3 by 4.1 millimeters. And the lumen itself is probably closer to 3.5 or so. And then IVUS run number 2, this is our LAD back to the left main.
That was the ostium of the circumflex.
You see relatively undiseased proximal ostial LAD. There's this left main stenosis. And the left main itself gets pretty large in caliber. If you click on B1, this is our Prox LAD EEL dimensions, about 4 to 4.4 millimeters. And then B2, this is our minimal luminal area. And then B3, this is the mid shaft of the left main, close to about 5.75.
All right, and we're going to show you our approach to DK crush. So we've pre-dilated, we've got wires there, and the first thing I'm going to do is I've got a 4015 balloon that I'm going to put for our crush balloon. That's sitting in the left main LAD, and we have a 3515 Zions that we're putting in the circumflex. It probably could accommodate a 40, but it's a distal edge that I'm not so happy putting a 40 in.
And the new Zions platform, the 3.5 and the 4.0 are the same stent, just different balloons, and they both post
Okay.
575.
Go negative. So let's see. Are you guys happy with that positioning? Give me a puff of the circ.
Yes.
I like it. Go ahead. So we're going to deploy the circ.
So it's 12,
14,
14,
16,
16.
down.
Looks
Take
big.
a look at that pressure. We've got impella support. That's why we have impella support. So I'm going to let her pressure come up.
Pull this out.
Shami, why a 4.0 balloon? Why not a smaller one?
So I almost always size it because I want to crush that stent. And I think that's one of the things where if you want to crush the stent into that circumflex stent, if you use an undersized balloon, you're not going to quite do that. So the whole idea in the DK crush is we want to crush that stent. And then we're going to recross it.
Yeah, I agree with you, Shami. It's hard to get that main vessel stent in if you don't crush it adequately.
And so now,
And a common you wanna pause mistake. For a second?
Everybody has a different approach. Some people leave the wire in, some people don't. I tend to take the wire out of the circumflex at this point. And so the wire in the circ is out.
Shami, can you put it on pause for a second?
And now there's my balloon that I'm going to use to crush. To give me just a puff.
Just going back to the IVUS and our strategy for DK crush is it just shows, first of all, the limitation of the angiogram. You know, we all thought there wasn't that much disease in the circumflex and we should stent from the LAD and use a provisional approach. The IVUS taught us something different in that there was not that much disease in the LAD. But paradoxically, we still are obsessed with the LAD, maybe appropriately so. I still think looking at the LAD that, you know, edema is not impossible. But if you think about the failure mode of the distal left main, it's the side branch, and there's something special about the circumflex origin. We're going to hear about that in a couple of the talks in a few seconds. So perhaps if we think about the failure mode of bifurcation stenting, maybe we should be treating the LAD as the side branch, because if the side branch fails, they can still get a good treatment, which is edema. Whereas if the circumflex fails, then, you know, we're fooling around with another stent and drug-eluting balloons and blah, 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 and under expansion and all that stuff. So maybe we should be treating the LAD as the side branch in the DK crush and going from the left main into the circumflex with the stent. Just something to think about, because even the IVUS here showed us that the disease is in the circumflex, not that much the LAD, but yet we're like giving special nation status to the LAD.
So Duane, you're putting all my teachings to all the fellows that I've ever done upside down with that concept. So it's tantalizing. I mean, I'm always telling the fellows, listen, you got to protect the anterior wall. That's the most important vessel. But it's interesting. Your point is that if we do all this and then the circ ostium is restenosed, and then what a painful process that is. And that's often the failure for DK crush when it does fail. it's that circ ostium. So if we went the other way, would that change? I don't know. But boy, you're gonna have to change the entire world paradigm. So let's go through a few more steps here, and then we'll have some time to pause and maybe talk about a few things, because you're gonna see that not everything went smoothly.
We
good.
have only 15 minutes.
And go ahead.
Ehtisham, our time is little
8,
running
8,
out,
10,
so we have to
10,
move a little
12,
quickly.
14.
And that's a good technique, one-to-one size of this balloon, because otherwise you may get trouble getting the wire in if it's partially crushed.
Exactly, and so one other point I like to make, and I'm not even sure I got a good crush there, but I like to kind of run this balloon back and forth once I've done this crush, before I'm going to go and recross. I'm going to do one more. I just noticed that she doesn't tolerate this inflation very well, so I'm going to wait a little bit.
Ehtisham, we are not seeing
Do
your
one
screen.
more inflation with a 4.0, and then we're going to recross. I'll take that run through, please.
But
Ehtisham,
that
can you hear
segment
me?
that you're dilating here, you're going to cover completely with
Can
your other
you
stent, right?
we are not seeing your screen.
That is correct. Go up.
And if you could move a little faster, please.
So we're going up again. This is crushing the circ.
12, 14,
16,
16.
and down.
But we are not seeing the screen. We are just seeing you. We are not seeing your screen. So you need to share the screen, please.
Okay.
Yeah, now we can. Now we can.
Now you can?
Yeah.
Okay. All right. I'm not going to replay it. All that happened is the 4.0 balloon was inflated high pressure left main to LAD. So now we've got a wire down in the LAD. We have deployed the circ stent and we've crushed it. And now we're going to cross into the circ to do our first kiss of the DK crush. You guys are way too quiet.
So did you pull the balloon out, or you're just parking it, so we're going to use it for
You
the
know,
kissing?
I always end up pulling it out, Gira, just because I find that it gets in my way. But certainly, you could park it. So now,
You make it look so easy.
well, you know.
Maybe we should hook it up to the robot.
Okay, so now we have a wire down into the circ, and we still have the wire in the LED. I'll take a fresh 3515 NC emerge. So I'm going to do my first kiss with the NC emerge. I'm not sure it will cross, but I'm going to try. If it doesn't
What
cross,
size, Shem?
so I'm going to do a 3.5 NC in the circumflex, and I'm going to have a 4.0 left main to L. So I'll just mute those panelists because we have live panelists now. So the question right now is what balloons to use. So at least my approach in this is there'll be 3.515 NC balloons, both in the circumflex and from the left main to the LAD for the first kiss.
Shyam,
Rain, your thoughts or?
any preference
Yeah,
for
I can't
the
do
wire for
I can't do the
recrossing?
math well enough to do 0.67 and all that sort of stuff. So I just size 1-to-1.
So approximately the left main was 5.5 to 6, so it will have to accommodate these two balloons, but I don't think there should be any issue with that.
Yeah, but I think the short comment that was made about selection of stent is very important. Here it's at least 3.5. You don't really have to make a big decision going 3.5 to 5.75, but not all stents, particularly, the sciences do, but and the synergies do, but not all stents can get up to 5.75, 6. And if you pick a 3.0 stent, your options are even more limited. So you might want to put in, even if the IVUS tells you that you should be putting in a 3.0, you might be wanting to put in a 3.5 stent at low pressure just to take the proximal left main up properly.
Shyam, we have 10 minutes left, so you have to move a little quicker. I'm sorry for rushing you, but we have to move quick.
Yeah, not a problem. You're not rushing me at all. What I'll do is I'm just letting this play while we talk, and let me get to kind of the crucial, there's sort of two very important and crucial points. So let's see where we're at, and I'll fast forward to those 2 points.
Do you have any preference for a particular wire to recross through the crushed stent?
So that was one of the questions that was brought up by one of the panelists. So I'll use a run through. If that doesn't work, BMW, Whisper, and my sort of the new generation wires are my kind of backup. So Xi'an blue or black is what I will finally get to if I can't cross with any of the steps that I just outlined.
And it's delayed because it's a taper, so it's a long taper.
So again, our goal here is to get a good result with our first kiss. So this is the first kiss of the DK crush.
So let me, so 2 non-compliant balloons, first kiss. I'm going to go a little forward here to a point of our next stent because the next part I hope we've not. So I think this is an important point here. This is after the first kissing balloon inflation. You see there's a little bit of haziness in the ostium of the LAD from the distal left main into that. And that's clearly a dissection. And the question here is, okay, what size stent to place? And what are the key points there? So for this particular case, the idea was to make sure that dissection is covered and to make sure there's enough in the left main to be able to do a pot. So very important points of learning for everybody is that you don't want the stent to be so short in the left main that you can't have at least an 8mm balloon to be able to post-dilate the left main. And you also want to make sure you completely cover this dissected segment.
Yeah, I might IVUS the LAD one more time just to see how far the dissection extends. But I think you got plenty of room before the diagonal. You could go 38, 48 here and not really worry much about it. I mean, just cover the whole thing. But I might just IVUS the LAD one more time.
Okay, and that, Sunil, for you would be to really determine whether or not it needs a longer stent.
Yeah, I just do sort of a quick poor man's co-registration when I see the normal vessel and just do a quick cine burst and freeze it there. And then you say, okay, well, I can probably take a 38mm or whatever. I know where the dissection ends.
Right, right.
So I think the fact that you are not stressed out right now, the patient's pulsatile and hemodynamically stable, I think all of these things are on the table. I don't know if she's having any chest pain, but you can see in the last few frames that the LAD is dissected like 15 or 18mm into its proximal segment.
Shami, if you can just please conclude it like what you did finally. As I said, I'm sorry, but the time is like we have 5 minutes left.
I've got 5 minutes, right? So 5 minutes, you're going to get to see all the good stuff. So
Yeah.
This is perfect. So this is really important. This is a 4023 Zions from the left main to the LAD. So this gets deployed here.
So the dissection goes a little bit further, but it's okay because you're going to get it on the proximal side at least.
Well, yes and no, Duane. You picked up on that. So the 4023 Zions is in place. We deploy that. And now the question is, what is the next step for this patient? And the next step would really be a pot. And so we decided we were going to pot the left main with a 5-0. So far, we've got the circ stent, we've got the left main to LAD 4023 Zions. So that looks good. Then we go ahead with a 5-0 pot, and I'll go forward to that. So here's what things look like. So I think your dissection is covered, Duane. Are you happy with that?
Maybe
I don't know.
you need another view just to see the mid segment of the LED that is not clear in this view to decide about the landing zone.
Yeah.
Okay. So the stent's already deployed, and it's
you also have
proximal to
the
the
IVUS.
diagonal. But you see that at the very ostium of the LAD and the distal part of the left main, there's still some kind of a residual.
Yeah, I'd be feeling very confident here, but I would take the left main a little bit bigger because we knew it was 575, and then take a cranial view to look at the mid or IVUS it, because that angiogram where it was dissected looked like to me like it went further.
And this is the rule of the IVUS to determine whether you need a bigger balloon or further inflation or what.
Right. So we had done the baseline IVUS. We knew that the left main was larger. And so now for this pot, the side branch circ wire has been removed, and we're coming in with a 5-0 balloon in the left main for the pot. And so let me go forward, and just because time is of the essence, we did the pot, and when we did the pot,
So if you could just tell us what you did, and please go to the end. You're almost out of time.
So here's the pot. This is, I think, Bashir, there's just one point, and then I'll go to the end.
Okay.
So this is the point. This is after the pot, and what you see is you've now got a closed, the LAD at the distal edge of the, I'm not sure why
It's like an extensive intramural hematoma that's compressing the vessel.
Correct.
Yeah.
So what happened is it's not an edge dissection, which is commonly what's thought, but what really happened is that intramural hematoma, Sunil, which is like, because with the final pot, there was no balloon out into the LAD. It was just at the distal left main into the ostium of the LAD. And following that, this happened, which is the intramural hematoma extending all the way out there. And so the next step was we put a long stent from the edge of that distal. So we put a stent, covered that diag with a 3020, and then we came back, recrossed into the circ. And let me show you the final picture.
You got a wide open LED to deliver that long stent, which is nice. I mean, you probably didn't struggle very much to get that long stent down there.
Beyond that, there really was no issue whatsoever to get that final piece across. So I'm just waiting for this to catch up so we can see the final picture. And the question of the value of hemodynamic support in this particular case came to be really around, all of this happened. There were about 2 minutes in this case that she was having a fair amount of chest discomfort and she got quite hypotensive. That 2 minutes is when that LAD, the hematoma had extended into the LAD and we had compromised flow. And once we got a stent in, everything turned out just fine. And that becomes the question. So here's the final result. And this final result is with recross and a final kiss of the left main LAD and diag. And the LAD itself looks fine because now we've stented beyond the hematoma. So
great result.
Shami, great
so
result.
that's the question for everybody. Our panelists, both in Pakistan and virtually, is hemodynamic support, was that necessary? Did it actually change our outcomes? Did it make the procedure safer? I would say definitely made the procedure, it made my life safer and gave me time to sequentially address this particular complication.
Thank you very much, Amir. It was an excellent result and excellent case representation. We are kind of short of time. I would like to thank all my panelists virtually, Sunil, Ramesh, Dr. Magdi, Duane, and unfortunately, we couldn't interact that much from our side, from the panelists from our side because of the case, but it was a great case. Really, you showed robotics also. Although I don't know, I always feel kind of uncomfortable. Nobody sitting there. If somebody was like outside playing with my heart over there through the computer, I would be uncomfortable. But I guess you have shown that, and you have been doing this for a while, that it is possible and can be done. But thank you very much for arranging this. And I know you tried your best to do the live, but unfortunately, for reasons beyond your control, you are not able to do. But I think this was a great case to show us, very complex, very difficult, with an excellent result. Thank you very much, everyone.
Great. Thank you very much for having me. Appreciate it.
So we are going to move on. I think I would request our panelists if they could come up here. We have the screens available here. You can see it as well. So the panelists can come up and join, please. We are going to move on. Our next is going to be a talk related to actually this live case we just showed. And it's by a very good friend who has been here to Pakistan in the past. And he's again an excellent interventional cardiologist, president of Chicago Cardiology, practicing over there, peripheral, coronary, and everything, and does an amazing job. So I requested him to talk on how should we treat an isolated LAD or circumflex ostial stenosis. Parag, are you there?
I can hear you. So
Can you hear, Parag?
Yes, I can completely hear you. Can you guys hear me well?
Okay, thank you very much. So you can start. You have 10 minutes to cover this talk. Thank you very much for being here and be part of it. I know you couldn't make it this year, but we'd love to have you next year, inshallah. Please go ahead.
Thank you, Bashir, and thanks to all the faculty. And it's been wonderful to be in Lahore and Karachi for the past meetings, and I promise I'll be there next year. So at least I'm here virtually to talk about ostial LAD or circumflex lesions. So very first question that comes up, now I'm not going to spend time on it, whether we consider bypass versus PCI. And obviously factors like patient age, comorbidities, prior bypass or other surgeries, diabetes, as well as patient preference. Also, LAD versus circumflex. Lima to LAD has excellent long-term data, and for younger patients, it's not an unreasonable choice. Also, associated right coronary artery disease, as well as additional lesions in the same vessel, whether they are bifurcation, whether they are calcified, and of course, your local resources and physician skill set. So, for example, for Pakistan or India, it may matter when you are going to do, if you're going to require Impella 3-4 stents, it may be more economical for the patient to get a bypass surgery as opposed to stent. So I'm going to present a quick case, 77-year-old patient with a previous aortic replacement with bypass to PDA 2010. He also had a biventricular pacemaker for cardiomyopathy in AV block, and he recently developed new onset chest pain with the pharmacologic stress test that showed large area of infralateral ischemia. This is his angiogram. As you can see, he has a severe ostial left circumflex lesion. There's about 60 to 70 degree takeoff. LAD appears healthy and plaque may be extending into the left main, and it probably is. There is a little overlap. So how do we approach this lesion? So let's go back. So the factors that influence the treatment of the ostial lesions. Number one, bifurcation versus stratification due to ramus, or if there is a near ostial OMO diagonal that increase the complexity. Number two, I'm also influenced by the left main bifurcation angle, and I'll talk about it a little bit later. Whether you have any disease in the left main, and whether it is LAD versus circumflex, as we discussed. So when you talk about specific lesions, these are some of the points. Almost all ostial and LAD circumflex lesions do have some plaque extension into left main when you do the IVUS. So when in doubt, stent should include left main. Single stent strategy is almost always superior to planned dual stent strategy, not when there is a significant disease in the second vessel. So you cannot leave a vessel that was diseased behind. And IVUS is obviously important in almost all of these cases for planning as well as after the stent. I always tend to use 8 French, but minimum 7 French guides should be used. Just to remind you, and I'm going to use this Medina classification as a left main as a proximal, and we really are talking about 010 or 001 for ostial or isolated lesions. This is my simple flow chart. I decided for this talk that what do I do? So I try to divide it in whether the left main is disease or left main does not have disease. So the left main does not have any disease, then I look at the angle of LAD and circumflex. If it is a wide angle, I usually put an ostial stent in the lesion with a little protrusion into the left main, and you may need to occasionally dilate the second vessel with the kissing balloon. If it is a narrow angle LAD and circumflex with clean left main, you can perform the ostial stent at high pressure in the lesion with a little left main protrusion and then moderate pressure kiss into the normal vessel. However, if you have left main with disease, then I again look at the LAD circumflex angle. If it's a wide angle, I usually perform left main to the lesion crossover stent, and I only dilate the second vessel ostium with a kiss is needed. If it's a narrow angle LAD circumflex with a left main disease, I usually do the left main to lesion crossover, and most likely I will end up doing the post and kiss into the both vessels, just so that we don't have compromised vessel. If I'm performing without left main crossover, just a simple ostial stent, I always wire the second vessel. You don't need to be precise, otherwise you leave some plaque behind. So stent in general should protrude a bit into the left main unless you have a really good angle. IVUS is extremely important to make sure that your left main is clean. And you should be prepared for a provisional second stent if needed. If you are performing a crossover stent from left main for the ostial vessel, I always wire both the lesions for the pre-balloon. After I perform the PTCA to the culprit vessel, you perform the stent crossing over from left main into the culprit, but I do leave the second wire in. I do make sure the left main portion is at least 6 to 8 millimeter stent coverage, depending on what balloon you have, so that you have enough coverage for part. And after the stent, I rewire the normal vessel from the struts and remove the wire that is buried underneath. After that, I perform parts, the proximal optimization technique, where you perform the PTC in the left main, but you do want to avoid inflation beyond the carina to provide, to make sure that the plaque does not shift. If needed, perform the final kiss, especially if it is a narrow angle anatomy. As much as we have talked about final kiss, etc., if you are going to be performing a single stent, I have reviewed enough literature. If you do not need to perform the final or second kiss for the side branch, avoid it. The outcomes without dilating the side branch are as good as with the dilation, and many studies have shown that if you try to dilate the side vessel after the stent, the outcomes may be worse with a more risk of restenosis. This was a fascinating bench study where they tried to replicate what is the alternate strategy. So idea is that there are three different groups. On the left, you have precise stent placement at the lesion. The second group got crossover stent, and third group got crossover stent with final kissing balloon. And all three lines represent different angle of left main LAD bifurcation. And then they studied the shear stress generated, which is a risk factor for restenosis. And some of the points that came up. So on the left, number one, crossover stenting only, but not precise stent, which gives optimal overall hemodynamic lesion. So if in doubt, do the crossover stent. Kissing after the crossover stent is actually hemodynamically detrimental. The lesions show more stress if you do the kiss after the stent. Bifurcation angle is a really important element when you consider a bifurcation lesion. Contrary to what we may believe, crossover stenting should be preferred when there's a right or obtuse bifurcation. And those are actually the lesions where there's possibly more restenosis. And if you have an acute angle, which is the very first group, then a precise or just an ostial stent may be appropriate. So in other words, if you have right angle or obtuse angle, which is a line 2 and 3, you are more likely to benefit from crossover stent. While if it's an acute or narrow angle, you may get there is a less stress on the lesion and less restenosis over a long term with a single provisional stent. So how did I treat this patient? We used 8 French sheet from the groin, 8 French AL1. Both vessels were wired, LAD and circumflex. We did perform the IVUS. Left circumflex showed complex dissected plaque, and the left main did not show dissection, but there was definitely some plaque. So we decided to proactively stent the left main as a crossover. This shows how we pre-dilated the lesion. This shows the stent placement with 3.5 by 33 Zions, which was deployed at 22 atmosphere. In general, I deployed the stent pretty much at the highest pressure. After the stent, we performed the part using 5 by 8. And then I do not have the picture, but we performed final kiss with the left circumflex 3.5 and LAD at 4 millimeter balloons at 8 atmosphere. And this was guided by IVUS. Post-procedure IVUS was phenomenal. And this was the result, and patient is doing fine. So I have a couple of more points. Simple is better than complicated, number one. Number two, crossover stent should be used more often than trying to land your stent precisely at the ostium. Number three, final kiss and additional stent should be only used as necessary. The data does not support it. Both are associated with high risk of restenosis in multiple studies. Consider larger guide catheter. It will make your life easier. And IVUS absolutely should be used for these lesions. End of talk. And I'll be happy to take the question and discussion.
Excellent talk. Excellent talk. Thank you. Our next speaker is Duane Pinto, and he's going to talk about, we continue in the same line, pearls and pitfalls of treating ostial, LAD, and left circumflex. Duane Pinto from USA.
All right, let's see if this works here. So I'm going to reinforce many of the points that I think, I'm going to, can you guys still hear me?
Yes, we can hear you. You can go ahead, please.
Okay. All right. So, I think it's been the major risk factor for LAD and circ restenosis is us. Us not doing the appropriate either All right, I'm back. Can you hear me?
Yes, we can hear you. It got just a little bit disconnected, but now it's okay. We can hear you. Go ahead.
All right. So, I think you've seen some of the challenges with ostial lesions in the LAD and the circumflex, stent positioning, the risk of stent dissection, as Shami's case showed, but more insidious is recoil and under expansion, mainly related to poor visualization if we only guide things angiographically. And this is where our patients are suffering an adverse dividend. Let's see if it advances here. So, I think some of the decisions when we're looking at left-sided ostial lesions are, as mentioned, do you want to stick the landing? Is there a nub? Or do we need to cross over and stent back into the left main? Do you need lesion preparation or not? If so, what are you going to be using, knowing that you might need to have a wire in a side branch? Perhaps that may move you towards lithoplasty if you have it available, but of course, cutting balloon inflations or standard atherectomy are what are more of our standard approaches. Do you cover all of the angiographic imaging disease or not? How much is too much? We had a small debate about whether an EF of 41%, 45%. Well, what about on IVUS? Do you treat at 30, 35, 40, 45, 50?
Can you share your screen? Are you just talking or we are not seeing your screen?
Sharing. Okay. Let's see, let me try it again. Do you see it?
No.
Now it is.
How about now?
Not yet.
Yeah?
Just seeing
Okay.
you, not the screen.
We can see their screen, Pinto. I can see it from my computer.
So it says that I'm sharing the screen. I'm not sure. I think the panelists see it, so perhaps there's some other
we
issue.
see it. Yeah, we see it.
So Bashir, you're not seeing it?
No, still not yet. No, it was there. Yeah, now we can see it. Now we can see it. Go ahead.
Okay. And then, once we figure out where are we going to cover, how are we going to deal with sizing and lengthening the stent? What about tapering vessels, as we mentioned? And where do we position it? Do we land in plaque or not? And then how aggressively to post-dilate? And, the truth is that we don't do a great job. Proximal miss, or the true ostium is missed in almost half of the cases. Proximal miss about half the time. And when the lesions aren't treated properly, there's a threefold risk of TLR, increased risk of TLR. So if our desire is to replicate Lima-like outcomes, I think we have to do a better job. So how do I treat it? Much like Dr. Doshi, he had some very important pearls that were given, but the careful choice of the fluoroscopic view that you're going to work in, intravascular imaging and lesion preparation, depending on what you see is the nature of the plaque, is important. Try not to land the stent in a significant lesion because you might thereafter have a problem, or in the very least, the person perhaps has an increased risk of restenosis. Post-dilate with a large enough balloon to maintain the taper rather than leave a stent, as you'll see in a very quick case I'll show you. I'm not going to belabor these points about the angle that Dr. Doshi mentioned earlier, but suffice to say that the angles less than 75, you can see the challenges related to plaque shift, carinal shift, and positioning the stents, because obviously in an angulated vessel, it's hard to actually nail the ostium circumferentially. And then I also want to point out that if we're not treating the calcium or fibrotic lesion properly, we lead to either stent malapposition, which is less of a problem than underexpansion, which is frequently seen in our patients with restenosis, where you see in this cartoon that the reference vessels show that the place where we put the stent did not fully expand. So in the top we have malapposition because of the plaque, but the central lumen or the minimum stent area is acceptable, where it's not acceptable in an underexpanded stent. And we should have treated this a little more aggressively. Just to get us closer on time, just that last conclusion is probably the take-home point, is we all know that ostial lesions restenose more, but they're also more fibrotic and perhaps require more radial strength or need us to prep the lesion a little bit better. So underexpansion is observed in about 40% of patients who underwent post-stenting IVUS in this small study. But, I come from a lab where Rick Kuntz, Rob Safian, Don Bain used to practice here. Don Bain was my cath lab director for a period of time. And they purported the bigger is better theory. But I think when it comes to bifurcations, that overdilation and deformation of the carina could be badder. So bigger is badder in some cases. So if we try to hyperexpand the artery, perhaps we not only risk dissection and perforation, but we risk deformation. And when it comes to the circumflex, if you are stenting from the left anterior descending into the left main, carinal shift occurs and a narrow angle is associated with greater narrowing of the circumflex. It can be 10% or even more than 10%. And perhaps we don't worry about that too much if there's not that much disease. But overdilation may push us into a two-stent strategy where perhaps we did not need it in the first place. So I think, again, for a different reason, intravascular imaging can help us because we can optimize our post-dilation sizing in that case. So very quickly, I'll show you a case, a 49-year-old man treated last week, right coronary artery, and then you see an isolated Prox LAD lesion, or so we think. Is there anything involving the left main? How far does that plaque go? Is there a stump to land in the LAD? And maybe we'll take a quick pause for the audience, the panelists to vote. So should we cross over or should we nail it?
I think here the CX, it looks fine, and unless you see something unexpected in the IVUS, the issue here is a discrepancy between the size of the left main and the LAD is great discrepancy. So which size of stent that you can use for this LAD and also left main, unless you like to dilate first to get the real size.
Duane, can you move on, please, because of the time?
Yeah, sure.
Thank you.
So I think a couple of points that are elucidated by the IVUS is the LAD, apart from the lesion where our eyes are drawn, still has quite a bit of disease. You see in the top left corner, the mid LAD. And again, we can decide whether we want to treat that or not. The Prox LAD was very tight in this young man who actually had been exercising with indigestion type symptoms. Right at the ostium in the bottom left corner, you see the LAD with disease in this nub, which we think, oh, maybe we could land it. And the circumflex origin is free of disease, but you see the left main playing there, and there is some disease that involves the left main. And again, it's a judgment call of whether to leave that disease alone or not. In this case, I elected to place the stent in the LAD back into the left main. And based on sizing, Dr. Magdi, I knew I'd have to take it above 5 millimeters. So we put in a 3.5 millimeter Zion stent because it will be accepting up to 5.75. I post-dilated it with a 6 millimeter balloon. After seeing on the IVUS here that it was profoundly malopposed in the left main, it was just too small, of course. And so this is the post-dilation. And I left some actually in the LAD, knowing with differential expansion, not going up to very high pressure, that it would post-dilate appropriately. And I also elected to cover the distal disease. And this is the IVUS playing at the end of the procedure, and hopefully the angiogram plays too. And that's the final result.
Excellent.
So we used a 6.0 balloon because there wasn't really a 5.75 balloon. Post-dilated the LAD to 4.0 based on the IVUS, no distal edge dissection, and we covered that that moderate disease too that was in the mid portion just around the diagonal there. So finally, to summarize, I think the decision of whether to stick the landing or stent back into the LAD, as Dr. Doshi said very nicely earlier, is dependent on imaging the plaque, characterizing where the plaque is, determining the angle of the LAD and the circumflex, and deciding whether you think there's going to be carinal shift or not, lesion prep alone or not, a low threshold for atherectomy, and plaque modification because of how fibrocalcific the disease is. You don't want to put in a stent that is underexpanded. I tend to be a little more aggressive with lengths of stent based on what I see on the IVUS because I don't want to land a stent in the middle of a plaque. I like to go from normal to normal, but I also plan the size and length of the stent based on the taper of the vessel, or in this case, whether the stent is extending into a much larger parent vessel. And then how aggressively to post-dilate the stent, I try to make an informed decision, again, based on the imaging rather than just guessing. Maybe it should be a 5.0 or a 5.5 or a 4.0 or 3.5 and possibly making a mistake on either side. When it gets to very large vessels, I have a hard time actually estimating size. I can kind of tell the difference between 2.5 and 3.0, 3.5, but when it gets to above 4.0, it's hard for me to know whether it's a 4 or 5 or 5.5 vessel. So with that, I'll stop, and thank you very much. I wish I had the time and the ability to come to Islamabad. It's definitely on my bucket list to see Pakistan. So I hope to be invited next time, and I'll do my very best to come. And thank you so much for allowing me to speak with you.
Thank you very much,
Duane.
Duane. It was a great talk, and a great talk from Parag also, Dr. Doshi and Dr. Pinto. We are very grateful, and Dr. Magdi also being there at this time. Again, I'm sorry because of the time, we have to move on to the next talk. So thanks a lot. If I know it's late for you people, if you have to leave, that's fine too. Thanks a lot. I really appreciate it, and next year, inshallah, we'll definitely invite you. Okay, so I'm going to request now, I think all of us know him very well, Dr. Professor Xiaoliang Chen, who has been a great friend of Pakistan and has been very supportive of Pakistan Live, coming to Pakistan very frequently, doing a lot of work in Pakistan. We are so grateful that he always, despite being so busy, he always makes a point to come to Pakistan and support and help us in Pakistan Live. He has been the co-director of Pakistan Live as well. Thank you, Dr. Xiaoliang Chen.